I'm Matt Hadfield. I'm a third-year medical oncology fellow at Brown University in the Llagaretta Cancer Center in Providence, Rhode Island, and am soon to be a faculty member specializing in early drug development and melanoma. And I am joined today by Jethro Hu from Cedars-Sinai and Morana Vojnic from Lenox Hill. And we are going to have hopefully a very spirited and lively conversation about Brain Tumor Awareness Month. So with that, I will maybe let you both introduce yourselves and give a little background about your involvement in the field.
Sure, I'll go ahead and kick things off. I've been at Cedars-Sinai for the past 15 years and see a lot of patients with lots of different types of brain tumors. And on the one hand, of course, treating patients with brain tumors can certainly be very challenging, but it is also very exciting to see basically the progress that's been made. Definitely more ways that we need to go, but we're on the right track.
And I'm Morana Vojnic. I'm a medical oncologist from Lenox Hill Hospital, Northwell. I see primarily brain tumor patients, primary or secondary brain tumor patients. And as both of you have said, I think it's a very challenging but very exciting field, especially given that the future seems much brighter than the past. We still have a long way to go, but there is some new exciting data, and I think hope we can provide for our patients.
No, absolutely. And I think, when I think of brain tumors, we see quite a bit of, metastatic disease from, melanoma and non-small cell lung cancer. But glioblastoma is something that's very relevant here in Rhode Island. As I was mentioning before we started this conversation, we have some of the highest rates of glioblastoma in the country, which is alarming. But to play off that a little bit, we do have we're right off the heels of the INDIGO trial, plenary session at ASCO last year. And starting to see some promise in IDH1 and 2 mutated glioblastoma. So maybe we can talk about that a little bit. How that trial has changed the landscape of treatment, and where you see targeted therapies going next in terms of glioblastoma.
I think that trial is particularly interesting. I mean, it was designed for primarily low-grade tumors, clearly, non-enhancing, that were IDH mutated and didn't need really immediate therapy. So chemo or radiation therapy post-operatively. And it does show very, very exciting and promising data. And I think it's like one of the first ones where actually targeted therapy for primary brain tumors is proving some success. And I think we're all very excited, hopefully, that we're going to get this drug approved soon, because I know a lot of my patients are asking for it. I'm sure a lot of your patients are asking for it too all the time. But I think it does open the landscape a bit, where we're actually starting to think about primary brain tumors, not only, oh, let's give chemotherapy when chemotherapy is needed, but there's also this option of moving into the other cancer types, which the way we treat them, let's say for lung cancer, for example, we have targeted therapy for lung cancer. We have multiple different TKIs, so tyrosine kinase inhibitors approved in lung cancer, depends on different mutations. So the more we move that also into the primary brain tumor sphere, we actually get much more treatment options in a disease that traditionally has had very limited treatment options.
Yes, it always seems like for brain tumors, it's sort of the last as far as getting treatments that actually show efficacy. And there's been this promise of precision medicine and targeted therapy that's worked so well in some other cancer types, but for brain tumors has really been evasive with lots of failed efforts in the past. And to see a treatment that's a targeted therapy for just a diffuse glioma diagnosis show benefit is really, really encouraging. It certainly makes for interesting conversations with patients these days because, of course, a lot of patients come and ask us about it. And it's a conversation basically about what the results of the INDIGO trial showed, that phase 3 trial that did show a benefit. And that was for patients basically who were relatively recently diagnosed with their IDH mutant low-grade gliomas and had not yet received other therapies. And how to take that data and sort of extrapolate it into the situations that we come into in the clinic, patients who have already undergone some form of treatment, and discussing, okay, might this still be something that is potentially an option? There is potentially the avenue of obtaining ivosidenib off-label, and then, of course, explaining, well, going down that road entails, another further extrapolation of the currently available evidence. And it's just, this is what we do with our brain tumor patients on a regular basis these days.
No, absolutely, and I think another thing too, and to to push that conversation forward is also the fact that it is a one of the things about targeted therapies is that it's only opening up options for a certain segment of patients, right? I mean, across anything, in lung cancer, there's been all these advancements with tyrosine kinase inhibitors, and there's the KRAS G12C story, which has been amazing. Only if you are one of the patients who harbors one of these mutations, and I think that's the one of the questions in glioblastoma and other primary brain tumors is, if you don't have one of these sensitizing mutations, then the landscape shrinks for you considerably. And other therapies that have worked pretty well in other diseases such as immunotherapy and lung cancer or renal cell or melanoma really haven't panned out as much in glioblastoma and other primary brain tumors. Where do you think the field's going next for maybe the tumor agnostic type patients? The ones who don't have, or not tumor agnostic, but without sensitizing mutations. I mean, what landscape may change for them in the future to offer up some more treatment options?
Well, there is very exciting data. I think we chatted offline as well about more immunotherapies or vaccine-based therapies or even CAR T. The trials are still quite early. It's phase 1 clinical trials, the two big ones that were published, one from MGH and one from Penn, I believe. Correct me if I'm wrong. They're still just phase 1 trials, but I think the data is exciting, especially given the fact that this is moving into the glioblastoma world. In terms of precision medicine and precision oncology for glioblastoma, I mean, we always try to repeat molecular profiling whenever we get new tissue, because as you treat the patient, the tumor evolves and changes, which is totally logical, right? You treat, the tumor responds or doesn't respond to treatment, and let's say responds to treatment, and then the tumor will start growing again once it's developed some sort of resistance or bypass mechanism. So I think it's important to try to find out what that is. And if you get something targetable, even off-label, and if you're out of any good standard of care options, which we unfortunately run into this disease all the time, we just have to do off-label things. But I think it's important to always get more information, because also that way, to these patients who are also can be very young, you give them hope for the future and hope for good quality of life and longevity. And I think also the patient advocacy groups here are extremely important. Just having the brain tumor support groups that are available probably at every institution at this point, discussing with other patients who are going through the same journey, and having these months like Brain Tumor Awareness Month, so people are aware, and just sharing all the knowledge you have and all possible clinical trial options throughout the United States or the world for that matter, just to give patients more options.
Absolutely. Yeah, I would say from my standpoint, I mean, I don't know exactly where the big breakthrough is going to come, but certainly there's a lot of promise in immunotherapy and also with targeted therapy, precision medicine approaches. Hopefully kind of the next generation of those approaches where we're able to, not just take kind of the bare minimum next generation sequencing data, but basically able to incorporate more data regarding just the signaling networks that are involved for all of these tumors and understanding how they evolve over time. It does sometimes lead to kind of this paradox, I feel like, in the field, in the sense that on the one hand, it seems like the most promising approach, the approach that oftentimes resonates with patients most is like, kitchen sink, let's do everything, let's do a combination of all of these things. Whereas clinical trials, of course, are easiest to sort of define efficacy if you're just manipulating one variable, giving one treatment. And so sometimes that's kind of a challenge, is figuring out, okay, how do we do everything for our patients as far as, giving our very best. But on the other hand, we have to conduct these clinical trials in order to really understand what treatments are actually efficacious.
No, absolutely. And I think that's another great point that you bring up. Two things that I was thinking about, as you think about more novel immunotherapeutic approaches, and like what comes to mind is things like tumor infiltrating lymphocytes were just approved in melanoma. You have cancer vaccines, which require, again, promising data like the mRNA Merck Moderna vaccine in melanoma, very promising, and things like bispecific T-cell engagers. While they're incredibly promising and showing efficacy in other diseases and maybe applicable to primary brain tumors or metastatic disease from other tissue, tumors, you wonder how siloed those are going to be in big centers for a long time. I mean, in clinical trial availability too. I mean, it seems like as these therapies continue to roll out, more and more of them are getting complicated. They require manufacturing, they require customization, and I worry that some of those aren't going to be widely adopted across the country in centers that just can't muster up the logistics to be able to adopt them. Which hopefully I'm wrong about, but that's one of the things I've been kind of worried about.
And also eligibility criteria for a lot of these trials, they're very stringent. And unfortunately, a lot of patients do not meet the eligibility criteria for whatever reason. So just getting the pieces of information, because I think the hardest thing is when you're diagnosed with such a disease as a patient or a family member taking care of a patient, is getting all the information you can. Because while there is information out there, it's one thing if you Google glioblastoma, and it's another thing if you actually get some verified information. And I think with the development of patient advocacy for this disease, I think also, I don't know how you guys feel, but I feel like also access and the number of clinical trials has actually expanded. So I think there's more and more being done in this field.
Yes, I guess, I do feel like, again, as you were mentioning earlier, it's exciting that we have more targeted therapy approaches, and that there are treatments that are able to kind of parse out these subsets of patients that may respond. But sometimes I feel like it becomes even harder for a patient now to qualify for a clinical trial, just because they are so restricted sometimes in terms of their eligibility criteria, just looking for specific niche populations. So yeah, absolutely, it's very important to do. Clinical trials are very important. These resource intense trials are definitely, are really pushing the envelope. But on the other hand, it's also very important to try to make sure that we have options for patients to benefit basically from all walks, because certainly access to trials is not as equal as we would like it to be.
No, absolutely. And I think that's one of the most frustrating things, especially like, again, getting back to like melanoma, which has a significant amount of patients with intracranial disease. I mean, so many of the pivotal trials have excluded patients with brain mets, which, when you're talking to patients, you offer this regimen, and then you have to wait for real world data to sort of accumulate before you can really say how you think something's going to work, because they just weren't allowed to be enrolled in the trials, which is very frustrating for patients and very frustrating for investigators. But I guess maybe we could finish with one final thought. Maybe both of you could offer up your opinions and advice to someone who is diagnosed with the horrible disease that is glioblastoma. What's the first thing you would tell them, and what opinions or advice would you offer?
Well, it's always a shock, of course. I think it's important to always remember and recognize that when we talk to patients and are breaking the news to them about their diagnosis, it's oftentimes the worst news that they've ever heard in their entire life, and it takes a while to process. For patients, I think it's just this overwhelming flood of information once you open those floodgates, and sometimes the best thing for an individual patient to do is to really focus on their own health and well-being, getting better day to day, recovering from surgery, and to try to come up, basically have a team around them, their loved ones, their friends, their family, that can really help to kind of be gatekeepers for some of the information, because it's always so many well-meaning people that end up reaching out saying, have you tried this and that? And of course, it's this very slippery slope of interventions that are really exciting and promising, and then things that are just kind of a bit off the wall. And for patients to kind of have a strong filter or some system basically for being able to manage all of that.
And just to echo what Jethro said, yeah, when you disclose this diagnosis, it's basically the hardest news they've ever heard and their family has ever heard. And typically, patients are aware that the prognosis here is not good. However, it's important also to keep hope and make a plan, because the hardest part is the initial part. You get the diagnosis, you're in the no, you don't know what's going to happen. And then you start your standard of care, your radiation, your chemotherapy, and you see typically you're doing, oh, I feel quite okay. Oh, I can do this. Oh, this is happening. And then as time goes by, and hopefully a good time goes by, then you kind of live from those times where it's scan to scan. And that's what I typically tell patients in the beginning, or at least in the initial visits, is you are gonna kind of get used to it because you're gonna have a schedule in your mind of what you're gonna do. And then you're gonna be living from scan to scan. Because I think that MRI is always terrifying because you don't know, is this the MRI where I'm gonna see my tumor growing back or anything else happening? So just, I think having a schedule and consistency and living still your life in spite of your diagnosis, I think that's key here. Not putting your life on a standstill, because at the end of the day, nobody's their disease, and we have to still live our life and do things we like and not stop ourselves because the patient is not the one that caused their tumor to appear. There's nothing that they did. It's not because they were stressed out for a year over their life because of a divorce or something. I'm just making up anecdotes, but those are the things that I get asked. So there's nothing the patient did to cause this disease, and it's just now living with it.
No, absolutely. And I can't think of any better way to wrap up this podcast on Brain Tumor Awareness Month than with some really wonderful advice from two experts in the field. So this has been a great conversation, and thank you so much for joining. This was great.